Happy Friday, Baylor College of Medicine and friends of Baylor. Lots to talk about this week. In particular, I want to spend some time thinking about the hotspots worldwide and our friends in Botswana. So, we've talked about Botswana having the biggest problems in Africa, but actually their numbers are getting better. They're down to 26 per 100,000 cases, better than the United States. We're at 36 per 100,000. So very, very interesting, and I want to spend some time talking about them. It's an interesting country, 2.3 million people. It's one of the most sparsely populated countries, which is both a strength and a disadvantage. The strength is because they're dispersed, there's less opportunities to infect people, but because they're so dispersed, it's also hard to vaccinate the country. 12% of the population actually lives in the capital, the largest city, Gaborone. And Botswana is actually now moving its economy up, doing very well. It's a growing economy. And of course, my favorite thing is 35% of the GDP is related to diamonds. Now, how bad can any country be where 35% of the GDP is related to diamonds? So they're doing well. They're beginning to come down, so I'm very pleased with Botswana. And we had the opportunity recently to entertain His Excellency, the President Masisi, who came to visit us and renew our 20-year academic relationship. We have a great picture of the two of us and the gift that he gave me, which was 2 African dingoes. He explained to me that they have razor-sharp teeth and love to rip the flesh from animals, which reminded me very much of what it's like to work in the Texas Medical Center or be an academic physician. Anyway, let's talk a little bit about Botswana, because it reminded me of another pandemic that we've lived with for many years. We've spent about 80 weeks now talking about coronavirus, and frankly, I'm completely sick of it. Probably have another 80 weeks to go. But let's talk about another global pandemic that we faced, which was HIV AIDS. And I first want to give you a little context with our background with Botswana. So BIPAI, which is the Baylor International Pediatric AIDS Initiative, was established here at Baylor with Botswana and in collaboration with Bristol Myers Squibb Foundation. It began in 2000 and was upgraded to a Center of Excellence in 2003. And it was the first BIPAI clinic in sub-Saharan Africa. And now BIPAI has multiple clinics throughout Africa and throughout the world as part of Texas Children's Global Health Initiative. And it's really, really important because it was responsible, Dr. Klein established this, and it was responsible for treating many, many pediatric cases with HIV when there was no treatment, and was very, very successful. But even more than that, we worked with Botswana to establish the first medical school in 2006, and our own Dr. Major Bradshaw was the founding dean. And the great thing was President Masisi came to visit us to celebrate our 20 years and reestablish our international partnership, which is really fantastic. And so together with the country of Botswana and the Bristol Myers Squibb Foundation, Baylor has worked with that country to really treat thousands, hundreds of thousands of kids with HIV. So it was a wonderful trip. I love President Masisi. He's a great guy. And I look forward to visiting Botswana soon. But let's look at other countries that aren't doing quite as well. Our friends, we always look at the United Kingdom. They are now up to 67% fully vaccinated. If you'll recall, we talked about herd immunity. With the Delta virus, it's going to take over 85% to reach herd immunity. So guess what? Without public health measures, they're not doing all that great. They still have a high level of cases. Israel, which raced ahead of everyone, is up to about 68% of their population vaccinated. Finally coming down, but at a very high level. And guess, just like the United States, we're 64% vaccinated, and while we're coming down, it's at a very high level. And so, I think there's lessons to be learned. None of those countries, UK, Israel, or us, are anywhere close to herd immunity. We've all relaxed public health measures, and we're all having sustained infections. And if you look at the Institute for Health Metrics and Evaluation, we've talked about this. The projection is that in the current situation, we'll continue to live with this virus for a long time. And the only way to get it down is either adopting universal masking or vaccinating everybody. And the problem is, if you look at our vaccination status, this entire map of the United States ought to be navy blue, and it's not. And that means that as long as there are communities that are low vaccination rates, they're going to continue to sustain virus infections in the United States. And Texas happens to be the one of the states that is not doing as well as some of the other coastal states. We like to call ourselves the third coast. We should start acting like it. We're not is where we need to be. We have only 50% of our population fully vaccinated, and while our case numbers are coming down, it's not coming down fast enough. If you look at the hot spots, I'm going to do another shout out for our friends in Dimmitt County, doing pretty well this week. That's great, but we still have a lot of variability. I think you can see that from this map of Texas. And in the Texas Medical Center, while our numbers are getting better, I mean, having 2,000 cases a day last week, when I would feel comfortable with 40, means we're a long way from where we need to be, and we're still admitting over 200 patients a day on average, which is just way too many. Interestingly enough, the city is beginning to post their waste surveillance data online, which is great to follow. And the good news is you can begin to see that the viral burden is beginning to come down. And here's a good example of the viral load beginning to drop in our wastewater, which usually precedes a change by about 2 weeks, so that's good. But it's still at a very high level, so, Anyway, tests are now coming. Is a big part of the Biden plan is to have cheaper and more tests available, and to use that aggressively to try and control the infection. And many people have asked me, which test should I use and how should I use it? My sister in particular is all over me. When I have friends over, should I get everybody tested? So I thought I would spend some time talking about home COVID testing. And of course, in order to do that, you actually have to understand how tests are evaluated. So in general, tests are evaluated on their sensitivity and specificity. And sensitivity is the ability of a test to correctly pick up the disease in a population who have the disease. So if a test never missed a case, it would be 100% sensitive. And that's what you want. You want it to be able to pick up tests, but they're never 100% sensitive. So how do you increase sensitivity? Well, you lower the threshold that you make it a positive. So if you have a number value that it's a positive test, you keep lowering that number value to get more and more people sensitive. But when you do that, then you diagnose a lot more people with the disease that don't have it. That's called a false positive. Specificity is the proportion of people who test negative for the disease among those who do not have the disease. So as you increase specificity, the way to do that is you increase the value of that test. If the number is 40 to be positive, you make it 50, 60, keeps going up until you get to 100% specificity. The problem is you'd miss a lot of people then. And so you'd have a lot of false negatives. So in order to understand how to use these tests, so again, those tests, sensitivity and specificity applies to the test itself. And the way they'll do that is they'll take a bunch of positives and a bunch of negatives and try the test on it and come up with those numbers. But that's not useful in real life. In real life, you have to understand the background, the prevalence of the disease in order to predict what it means. So prevalence tells you how much disease there is in the community, and likelihood ratios take sensitivity and specificity and begin to tell you how useful the diagnostic tests are. And when you combine all of these into one concept, it really is, it's a Bayes theorem. So many of you may have heard about Bayes theorem or studied it in college. It's named after Reverend Thomas Bayes, who basically said, look, the probability of an event happening before you do the test influences whether or not the test is going to be positive or not. So it's called a pretest probability. So in other words, the pretest probability takes into account all of the characteristics of a test and then adds to them the prognostic data, how much disease is in the community, clinical factors, et cetera. And that's why when we say, well, we have a new test, let's just try it out. Well, you can't just do that. People go, well, why not? Well, because the amount of disease in the community will totally influence what the outcome of that test is. So let's just talk about a few of these, and I'll do some examples so we can understand for my sister how to use the test appropriately. So pretest probability is the chance that the patient has the disease even before we test it. In other words, how many people in the community have it. Post-test probability tells us the chance of having a disease after the test is performed. And so as you know, probably if you get a positive result from a test, a true positive, the person actually has the disease, but we'll have some people who don't have the disease that are also positive. That's called a false positive. You'll get a test result that's negative. And there'll be people who have the disease, that's called a false negative. And there'll be people who don't have the disease, that's called a true negative. So let's use this in real life. Let's make an example. We have a test that we're going to determine positive predictive value, and that is those who test positive, what percent of those will actually have the disease. So here's an example. We have 1,000 patients, 200 have the disease. And we have a test where 240 of the tests turn out positive. 160 of those are true positives, and 80 test positive without the disease. So they're false positives. So if we do the math, we have 160 positives that were divided by the total number, 240 times 100. So we ended up with a positive predictive value of 67%. In other words, a positive test in that example is right 2/3 of the time. Not 100% of the time, 2/3 of the time. Well, a negative predictive value is the same kind of thing. It is those who test negative, what percent are truly negative? So in this example, let's say, of the 800 that tested negative, 720 actually are negative, and 40 were falsely negative. And so we would calculate the negative predictive value, 720 divided by 760 times 100, it's 95%. So 95% of the time, when you got a negative, it's truly negative. So here, let's now add Bayes' theorem into this. And this is really important. If in the community there's very little disease, well, let's say the disease is only 5%. So there's 1,000 people, only 50 have the disease and 950 don't. And we have a pretty good test. We have 90% sensitivity and 90% specificity. Well, the test will correctly pick up 90% or 45 individuals that actually have the disease, so 45 of those 50. And it'll identify 90% or 855 individuals without the disease. So the remaining 5 will be classified as false negatives and 95 as false positives. So if we do the calculation, the positive predictive value is 32%. That's a pretty bad test. So in a low prevalence community, even with what you think is a decent test, you're only going to have a positive predictive value of 30%. In other words, most of the people you diagnose with that test are not going to have the disease. The negative predictive value, though, in a low prevalence community is actually really, really high, 99%. So when there's low prevalence, a 90% sensitivity is a really good test for telling you don't have the disease. Well, let's look at coronavirus now. It's pretty high, 20%. Let's say it's 20% in the community. So there are 200 individuals that have the disease, 800 that don't. So again, we're going to go with a pretty good test, 90% sensitive, 90% specific. The test will correctly identify 90% or 180 true positives and 80 false positives. So the positive predictive value is actually 69%. So the same exact test now in a high prevalence is pretty good. It picks up 2 out of 3. And if you look at the negative predictive value, it's 97.2%. So it's still pretty good. So, that in a high prevalence community, when you have a lot of disease around, the tests work pretty darn well. As you begin to lower the sensitivity to 70% now, so it's not as good, not the 90% sensitivity and specificity you had, but 70%. Well, the positive predictive value becomes 36%, and the negative predictive value becomes 90%. So it still remains pretty decent as a negative predictive value, but not as a positive predictive value anymore. So let's talk about problems with testing for COVID-19. So we don't know the sensitivity and specificity of the SARS-CoV-2 test very well. And we don't really know the true test prevalence of COVID-19 currently in the community. We can guess at it. We can say, well, it's 20% or 15%. So, in areas where it's high prevalence, like, in cities that have had a lot of disease, like New York City, it might be higher than in communities that rural communities have had less. So how do we use all this information to actually make an intelligent decision about how to use a test? So there are 3 major tests now. The Abbott Binax Now test, that's a rapid test. You swab the nose, it turns color in 15 minutes, and you come up with an answer. There's also the Illum COVID-19 home test and the QuickView test by Quidel. So the CDC has actually measured the Abbott test. And again, this is really important in trying to interpret it. What they showed was that in symptomatic people, The sensitivity, you remember I mentioned the example of 70%, the sensitivity is 64%. In asymptomatic people, it drops to 32% or 35%. It's pretty high specificity, almost 95 to 100% specificity. So if at high specificity, it's going to miss a lot of people who are positive, but if you're positive, you're definitely positive. So how do you use these tests? Well, if you're symptomatic and you raise the pretest probability, they're pretty good at identifying positives. And the negative predictive value is pretty good too. It's about 80 or 90%. So if the test is negative, so that's a good test. But if the test is negative, and symptoms remain, then you probably ought to get a PCR. Or you maybe do another antigen test. So serial testing helps you figure this out. But the point is, if you're symptomatic, these tests are probably pretty good to use as a screening tool. If you're asymptomatic, now all of a sudden you've dropped the pretest likelihood of having the test. They're not as good. And in fact, in that case, they're very, very low. And so a better approach, if you're asymptomatic and you're worried about having the disease, is to get a PCR test 3 to 5 days after your exposure. Or if you want to use one of these quick tests, you have to do it serially several times over the course of 2, 4, and 6 days. And one of the problems with these tests is if you're doing it at home, there's a big chance for making methodologic errors, timing wrong, swabbing wrong. So I think when asked about how do I use these tests, if your child is really sick or you have friends that are sick, it can be useful in doing a screening test. If it's positive, it's very likely to be positive. If you show up negative, there's still a reasonable chance that you'll miss somebody, but not as you're symptomatic. If you're more symptomatic, you're less likely to miss them. So I think they can be useful, particularly serially in children who are going to school. And if you become symptomatic, I think it's a reasonable thing to do. But we'll see. We really have to do more testing of these tests. But I want to emphasize, if you're asymptomatic and you're using these tests, these rapid tests, they're not going to be very useful. So on The View, bunch of people, they are asymptomatic, they do a bunch of tests, and guess what? More false positives than true positives. So they tested a bunch of people, they were positive because the positive predictive value is very low. Later on, they tested them with qPCR, it was negative. So there's a great example of how if you have a low prevalence, unlikely, the pretest probability is very low that you're going to have the disease. If you start testing people, you're more likely to have a false positive than you are a true positive. So the best test, when you really want to know, is to get the PCR test. But obviously the problem there is you don't like getting things shoved up your nose, and it takes a while. But the PCR test is the best test to really get a true positive. The other problem that's really important is the timing. So the PCR test becomes positive very early. The antigen capture, these rapid tests, take 2 to 4 days before you have enough protein, the viral products in your nose to be able to be positive. So PCR test is positive early on and stays on. The antigen capture tests or the rapid tests you can miss early on. So it's very important that you get the timing right, which is another problem with doing home tests. Okay, so we just talked a lot about how we assess tests. Let's actually figure out how to use it. So let's say you have a child that's going to school and you want to make sure that they're safe. Well, if they're symptomatic, the first thing is keep them at home. Anybody who's symptomatic, keep them at home. If you take the Abbott test and it's positive, well, they probably have COVID. So, very likely you don't have to go do a PCR, no problem. If they're symptomatic and negative, so you get a negative test, well, still keep them at home because there's a chance that it was incorrect, and do another test or get a PCR test. Let's say they're not they're asymptomatic completely, and you want to send them to school and be safe. Well, a negative test in an asymptomatic child is likely to mean that they don't have COVID. But to really be careful, because there will be some false negatives, you should probably do it twice a week, something like that. For adults, same thing. If you're symptomatic, stay at home. If you get a positive test and you're symptomatic, you likely have COVID. You don't really have to get a PCR test to know. If you're negative and symptomatic, you probably should go after a couple of days, if you're still symptomatic, get a PCR test to confirm, or do a second test to see if it's positive. If you're asymptomatic and you're just testing regularly, you're likely to not have COVID, but there are times when you miss it, so better to do it serially than just one test. So that brings up, like, what happens if I'm having a wedding or an event? Well, one time we know is not great. So the first thing, if you have an event, be sure everyone's vaccinated. Don't just say you have to be vaccinated to participate. But if you want, and people are asymptomatic and they get a test and they're negative, it's very unlikely that they have the disease because it's a very low prevalence in that condition. If they're positive by accident, they're asymptomatic but positive, they very well could be false positive, so they should get a test for PCR to make sure it's okay to come to the event. So I hope that makes it easier for you to understand how to use these tests. On the good news, Pfizer submitted its data for approval for 5 to 12-year-olds. There was about 2,200 participants between 5 and 12 years old. I talked a little bit about this last week. It's a 2-dose regimen of 10 micrograms. The adult regimen is 30 micrograms twice, but they use that because it's safer and more tolerated. The good news was it got a tremendous immune response. That data has been submitted to the FDA, and I'm hopeful that it will be approved hopefully within weeks, because parents really need it. I want to end this week with a giant shout out for remember your flu vaccines. We have teams getting flu shots right now. I want you to be sure to get your flu shot. If you're getting COVID shots and flu shots, one in one arm, one in the other arm is the easy way to go, probably separated by a few days, but there's no real risk to getting both. And then the second thing I want to remind people, we have an accrediting agency, the LCME, that looks to make sure that we're a sufficient medical school, that we do the right thing in medical school. We just had our accrediting group here. I want to give them a big shout out because they're doing volunteer work to make sure that the medical schools around the country are adequate in providing good medical education. And I want to do a giant shout out to our team, which did a great job in preparing for the LCME. So thank you all. Have a great weekend, and I look forward to talking to you next week.